Good evening, everyone. Thank you for joining us for our webinar on urinary incontinence in women. Tonight we will be hosted by Dr. Chris Webster. He practices out of our Westminster location here in Colorado. So I'm happy to introduce him and I will hand it over.
Thank you, Ashley, and thank you everybody for joining us this evening. I'm coming at you from my home office in Westminster, Colorado. And I want to thank you all for joining us on this beautiful Colorado night. We're going to just have an open conversation about urinary incontinence in women. We're going to talk about here in a minute about questions and how that whole process works. First of all, just a little bit about me. I go by my middle name. It's Chris. I'm a general urologist, but I do have some particular interests that I focus on a little bit more often than some of the other general urology, such as women's urologic health, which we're going to talk about some of those aspects tonight. I also do some robotic kidney surgery and robotic prostate surgery. You may ask your question, who's this guy and how did I get here and why am I qualified to take up 45 minutes or an hour of your time on a Tuesday night? Well, I'm originally a Floridian, like many Coloradans. I'm a migrant. I was born and raised in Florida. I went to the University of Florida for undergraduate, University of South Florida for medical school and residency. I had the good pleasure of training at the Modification Center at the James A. Haley VA, which is the busiest VA in the country, as well as Tampa General Hospital. After finishing training in 2007, I worked in Orlando in private practice for about 5 years. And then my wife and I decided that we were gonna have a grand experiment, and that was to come out this way. So this is my wife, the picture on your left of your screen, doing one of the things that we love to do, which is ski, and my 3 children. And I wanted them to grow up in an environment in the natural beauty that we live in here in Colorado. So we packed up our stuff and moved out here, and we're fortunate enough to join a practice out this way that was part of Colorado Urology, and kind of the rest is history. So I'm very excited to be here. While I miss my folks in Florida, I don't miss much else from there. You can only go to the theme park so much, and humidity does get old. Colorado Urology is a large conglomerate of urologists. We're actually the biggest private practice urology group in the state. We have offices throughout the metro area, as far north as Longmont and as far south as the Parker area. This is just a brief list of our physicians and advanced practice providers, and it's growing every day. I'm not the only one in our group that has an interest in women's urologic health. So even if I'm not in your geographic area, we can certainly get you with somebody who is and help out with any of your urologic concerns. Some of you may be thinking, well, aren't urologists men's doctors? And I've been asked that question many times at various social functions. And the fact is that about 45, almost half of my patients are women. And so women can get kidney stones. Women can unfortunately get bladder cancer, kidney cancer. Women unfortunately more frequently suffer from recurrent urinary tract infections than men. Women can have dropped bladders. And then our 2 subjects tonight, urge incontinence and stress incontinence, or leakage of urine. So that's what we're going to talk about more tonight. But certainly we see many women in our practice for a variety of different urologic conditions. So what is urinary incontinence and why do we care? Sort of medical definition of urinary incontinence is involuntary loss of urine. Some people might just call it great old leakage. Interestingly enough, urinary incontinence affects almost half of women. There's a recent landmark study that looked at the incidence of some type of urinary incontinence in women from age 20 to 80. And there was a 44% risk at any given time that ladies in that entire age group would have urinary incontinence. In addition, it's a huge economic factor. So the average amount of money spent on incontinence products, not medications, things like that, but pads, diapers, things like that, is $900 per person. So this is not an insignificant economic impact. And just urge incontinence alone, and this is a little bit older study, but back in 2007, was a $66 billion industry per year. And that was more than 10 years ago. So this is an extremely common thing that's just, unfortunately, just really not talked about. And as a urologist and as somebody who sees this sort of thing day in and day out, that last aspect is really frustrating to me. I really think that urinary incontinence, it's so common, it really should be okay to talk about. And I can't tell you how many women I've met before who've just said, well, this is just part of being a woman. This is just part of getting older. This is the sacrifice I've made for having my children. And I just don't believe that. I believe that if you have an issue that is impacting your quality of life and keeping you from doing the things you like to do, then it's not something you should just live with. And I'm rather passionate about that. Back in the 90s, before Viagra came around, erectile dysfunction was like, nobody talked about that. That was taboo. And now we have, commercials on people sitting in bathtubs talking about pills that, for men for erectile dysfunction. To me, incontinence should be at that same level of comfort for conversation. It should be comfortable dinner time conversation, in my opinion. When we talk about incontinence, that incorporates several different factors, if you will. And the two biggest are stress incontinence and urge incontinence. And this diagram is kind of designed to illustrate that. Now, overflow incontinence in the upper left, that is typically when somebody has nerve damage and their bladder is just so full it's overflowing. And that's extremely rare. Fistula, also extremely rare, is when there's an abnormal communication between the bladder and the vaginal area, usually due to some prior surgery or radiation or something like that. We're not going to cover those areas tonight because those impact such a small percentage of the overall population of ladies with incontinence. So we're really going to focus on stress and urge. And then there is something called mixed incontinence, which is represented in the middle of the screen here. And that's where there's overlap of both stress and urge incontinence. So we're really going to hone in on these two disease entities, what contributes to them, how I as a urologist evaluate them, and things that we can do with Colorado Urology to offer you help with these rather challenging circumstances. So the first thing we're going to go over is stress incontinence. So stress incontinence is basically when you cough, laugh, sneeze, pick up something, do a jumping jack, and urine comes out. And the stress is not, my husband's stressing me out. It is anything that increases pressure within the abdominal cavity. Risk factors for stress incontinence include obesity, childbirth, prior pelvic surgery like hysterectomy, pelvic radiation, smoking, and then pulmonary disease. And these last two is because that puts stress on the area. And it may also have something to do, particularly in smoking's case, with the impact of smoking on tissue quality within our body, collagen and things like that. So in this diagram, what we're trying to demonstrate, in a normal urologic anatomy, we have our pubic bone here, the bladder sits in this area, and the urethra sits here, exiting at the upper part of the vaginal canal. In stress incontinence, there's a lack of support for the urethra. So it's not like there's particularly muscle damage or something like that. It's just through these various entities, there's a lack of support. So when one coughs, increases pressure, stresses, the urethra actually moves, something called urethral hypermobility, and that doesn't have support and urine is expelled. So that's what they're trying to show here, is this is showing a lack of support and urine coming out due to an increase in pressure. When I see somebody in the office who's expressed concern about incontinence, we do a traditional evaluation, which includes a history and physical. And that history is basically, that can be done both virtually or an in-person discussion. And one of the things we're going to look at as far as the physical is, does somebody have a dropped bladder or are there other factors? In addition, we have some adjunctive testing that we do in the office, bladder scanning, volume diarrhea, cystoscopy, these sorts of things. And I'll review those with you in a little bit more detail. But specific questions that I'm going to ask during a history is, do you have children? How many children? Were they vaginal deliveries, complicated, forceps deliveries, big babies? We're going to talk a little bit about the number of pads you use. That's a method for us to determine, how severe is the circumstance, and a way for us to measure success with various interventions. We're going to talk to you about things that make the incontinence occur. Is this more stress related? Is it more urge related? Do you have mixed incontinence? If you do have mixed incontinence, which one is more predominant? Do you find that you leak more with urges to go, or is it more, I laugh or sneeze and urine comes out? We're also going to look for other things like history of infections, prior surgeries that would make you predisposed to incontinence, and any prior treatments. Now, when we look at these adjunctive testing, not every person needs these, but we do want to make sure that you're emptying your bladder and you don't have overflow incontinence. So we do a very simple test called a bladder scan, kind of like an ultrasound, but instead of a picture, it tells us a number, and that number is how well you're emptying your bladder. The other is avoiding diary, which is just like it sounds like. We ask you how often you go, how much you're leaking, what you're drinking, how that sort of thing. And then a urinalysis, most people are familiar with. That's a urine test that we use to look for things like blood in the urine, urinary tract infection, things of that sort. The other things we do a little bit more specialized, and we do these for both stress and urge incontinence, is a cystoscopy and a urodynamics. What a cystoscopy is a way for us to assess the anatomy. And, as a surgeon, the last thing I want in the operating room is a surprise. I want everything in the operating room to be totally predictable. I want to know who the people are. I want to know the products I'm using. I want to make sure everything I have that I'm accustomed to. It's just like when you're, getting on an airplane, you want the pilot to be totally in their comfort zone. So in order to minimize surprises, we do a little bit of workup beforehand. And that workup is designed to assess the anatomy and bladder functioning. The way that we assess anatomy is by doing something called a cystoscopy. Now, a cystoscopy is a relatively simple procedure, very straightforward, does not take very long. This can be done in the office or in a surgery center. And the idea is just to take a quick look. Most people are familiar with colonoscopies. That's looking in the colon, typically for colon cancer. This is looking in your bladder, and it's much less involved than a colonoscopy. What we do is we put a little lubricating jelly in the urethra, the urinary tube. We slide a little scope in there like a catheter and take a look around. The process is relatively quick, and it really has minimal risk to it. Maybe some mild burning with urination. Very rarely can somebody develop a urinary tract infection. But it really gives us a much deeper appreciation of the problem, and again, minimizes surprises in the operating room. So that assessment is of the anatomy. The other assessment is of bladder function. And so this is called a urodynamics test. And what I use this for is for a couple things. One is it tells me, are you urinating using your muscles in a coordinated fashion? And that's important because, I want to have a full picture of your whole bladder functioning so that we don't go down a path of treatment and come to find out, ooh, wait a minute, really there's something else going on, or we didn't account for this. So this is an in-office test done by a technician. We have a technician who does this all day long. It's all she does, and she's quite good at it. And so what it entails is placing a very tiny catheter in the bladder, about the size of a coffee stirrer. And that catheter has a pressure sensor on it. We put another pressure sensor in the vaginal or rectal area. And again, these are small, non-invasive, no needles, nothing sharp. But what those do is those measure that pressure and that stress. We fill up your bladder with fluid, and we get readouts that tell us what's your capacity, what's your sensation. We have you cough, bear down, and we see how much pressure does it take for you to leak. And I utilize that information in surgical planning because if it takes a very low amount of pressure for you to leak, I might recommend one particular type of treatment, versus if it takes more pressure, I might recommend a different type of treatment. So that test takes about an hour, done in the office, really valuable information that really helps us provide better guidance for determining proper courses of action and really being able to explain how you might benefit and going in the right direction for your particular problem. So when we look at treatments for stress incontinence, really we look at a couple of different opportunities here. With Colorado Urology, we're not about just giving you medication. We're not about just getting you to the operating room. We really take a multi-specialty, a multimodal approach to any given problem because we realize that every patient is unique and every patient's needs are different. So we really try to maximize different treatment options, not just medication, not just surgery. We try to work with people on lifestyle modification, stop smoking, weight loss. Certainly those things are easy for us to say, hard for people to do, and we recognize that. But, we want to be supportive of the whole person, not just, hey, here's a medicine or here's a surgery we can do. In addition, we work with people on some Kegel exercises. A lot of ladies are familiar with that, and those are appropriate for stress incontinence. not so much for urge incontinence. We work very closely with pelvic floor physical therapists, and I'll go over that a little bit further. And we also use treatments such as urethral bulking agents and mid-urethral sling. So, we really do try to tailor the approach to the patient goals and patient desires. We're really not about just, hey, here's what we have to offer. This is what we do. Therefore, we don't try to fit you into what we do. We try to fit what we do into who you are. So when we look at physical therapy, pelvic floor physical therapists are specialized physical therapists. These are not the same people you go to after a knee replacement or something like that. These are highly trained, they're highly specialized, that we communicate very effectively with each other and have an interdisciplinary approach. Their initial evaluation is to do a very comprehensive evaluation of your urinary habits. They don't replicate the tests that we've done, but they do muscle assessments, neurologic assessments, and then they come up with a treatment plan. So I kind of liken going to physical therapy like going to a personal trainer at the gym. So if you go to a personal trainer at the gym, they kind of talk to you about your goals, they do an assessment of your current circumstances, and then they come up with a treatment plan saying, you should do these exercises this many times, and you see progress over time. And much like a personal trainer, if you just go once a week to the personal trainer and you don't do the exercises outside of that, you're probably not going to make the same gains that you would if you followed the treatment plan, even on your own. So physical therapists use a variety of techniques: muscle retraining, stretching, scar tissue mobilization, home exercise programming. They can even do some internal manipulation. And again, I think that this is a large part of the puzzle. I think they offer a lot. I don't know that they can fix every problem, but they can certainly contribute to the solution to every problem. So I rely and work very closely with the local pelvic floor physical therapists, and I appreciate that relationship. Procedures that we do beyond lifestyle modification, beyond Kegel exercises, and coordinating with a physical therapist, there's really two mainstays for stress incontinence, at least that I offer, and that's a urethral bulking agent and a mid-urethral sling. A urethral bulking agent is a process by where we inject a collagen-type material within the urethra to bulk it up. So it's pretty much like it sounds. It's a urethral bulking agent. So these pictures show a scope going into the urethra, a small needle being advanced just underneath the surface, what's called the mucosa, and this bulking agent being injected. The nice thing about this is it's very simple. It can be done in the office, but it's a little bit uncomfortable. So I prefer to do it in a surgery center where you can give people a little bit of medication to keep them more comfortable. The benefit is it's a very fast return to activity, meaning there's really no downtime. You can have it done and the next day be, jogging, cycling, taking care of your family, what have you, back to work. The downsides are a couple of things. One is it may require additional treatments. It may work for a period of time and then symptoms kind of recur. I like a sling better, mostly because I feel like a sling really addresses the problem. When I was showing you the slides before about the urethra, nowhere did we say the urethra is too wide. It's an issue where the urethra is not supported. And really a bulking agent it's not supporting the urethra, it's just making the opening more narrow. Now, if you do this and it doesn't work, you can still have a sling, or if you have a sling and it's just not quite enough, you can go back to this. So one thing doesn't preclude another, but for my choice, I would do the sling personally, but this is not a wrong option. And some people just feel more comfortable going this route. When we look at the sling, mid-urethral slings are an outpatient procedure. It does require general anesthesia at this point, although we're getting advances in getting people to where they could just do this under some sedation and some numbing agent. It's typically done through a 2-centimeter vaginal incision. There are some restrictions afterwards as far as lifting, straining. We ask people not to have vaginal intercourse, use tampons, things like that for a period of time afterwards. Really, the thing I like about slings is it really addresses the problem, and I'll show some examples of that here in a moment. But there are some risks. There is nothing ventured, nothing gained, and those risks are extrusion, erosion, retention, new onset, frequency, urgency. And these are specific to a sling. I mean, with any surgery, there's risks of anesthesia, discomfort, bleeding, infection, but these are specific to a sling. So extrusion is where the vaginal tissue underneath the sling opens and it exposes some of the sling material, which admittedly is not a pleasant thing, but it's actually fairly easy to fix. And the incidence of that is around 2 to 3%. Even though you might see some horror stories out there on the internet or what have you, really that's not a common circumstance. And it can be treated sometimes with some estrogen cream to allow that vaginal tissue to heal. Or we can go in and remove that exposed portion of the sling. Sometimes that can be done in the office. Sometimes it's more comfortable under some sedation or anesthesia. But again, pretty low risk of that. Erosion is where the sling material goes someplace it should not, like into the urethra itself, into other organs, tissues. And that's a potentially significantly bigger problem because that has to be fully removed and those tissues that have been affected have to be repaired. So that admittedly is a significant deal, but the incidence of that is less than 1%. Again, if you look at the incidence of complications from really any intervention, less than 1% is pretty darn low. There's also a risk of the sling being put in too tight, and that can lead to one of two problems. One is if it's really tight, it can keep people from urinating. And there are cases where we have to go back and actually loosen the sling. The incidence of that is around 2 to 3%. There's also a circumstance where if the sling is a little bit too supportive, that can make it hard for the bladder. The bladder has to work harder to go. And when the bladder has to work harder to go, it lets you know by going a little bit more frequently, a little bit more urgently. So there is such a thing as new onset, frequency, urgency. In that circumstance, we sometimes do go back and loosen the sling, which interestingly often doesn't lead to a recurrence of the incontinence, which is kind of contradictory to my experience, but that's what I found in the handful of times I've had to go back in and loosen or incise a sling. Here's a picture of some different types of slings. And I mentioned earlier about with urodynamics testing, we measure how much pressure does it take to leak. And I use different slings depending on that pressure. So for instance, if somebody has a very low pressure for them to leak, they leak very easily, I might use a sling like the one up here on the upper left, which is called a pubovaginal sling. And that goes under and it almost shapes or hugs the urethra like a U. I don't know if you can see my arrow on the screen, but this is the urethra. There's two small, less than 1 centimeter incisions in the lower pelvic area below the bikini line. And then this goes and it's more supportive. It's like a U. So as that urethra moves, it has more support. This one on the upper right is something called a transobturator approach. It uses material that's more horizontal, but not quite as horizontal as the single incision sling. This has two small incisions that come through the thighs. This is another, relatively low invasive procedure. All of these things are done through really small incisions. The one issue potentially that's reported a little bit more commonly with obturator slings is some leg discomfort because this material, when it's put in, there's a small, tiny little opening in the inner thigh. Again, that's rare, but that is one thing that's more unique to the obturator approach. The sling that I use most commonly is called a single incision sling. It's shown right here. Unfortunately, I don't have something within that picture to show size, but it's about the size of my little finger. It has these little darts on the end. This is done through one incision. So there's no incision in the thighs, there's no incision in the abdominal wall, pelvic wall. But what happens is, this is an older version, we passed it through and then it has a little barb here that connects into this connective tissue. And then we pass it through onto the other side. And one of the reasons I liked this sling a lot was you were able to tension the sling. And so we were able to get it to where it was just supportive, not restrictive. And the whole art to this surgery is we don't want the sling compressing the urethra, we want it supporting. So there's a backboard of tissue when someone has stress maneuvers, cough, sneeze, jump up and down. That urethra has a backboard of tissue, but it's not compressing the urethra. And so I really like these single incision slings personally, but again, that's a surgeon sort of experience and choice. each of these has their advantages and disadvantages, and I use them in specific circumstances based on the anatomy and the bladder function. So that's stress incontinence. Before we move on from that, one just report about mesh. So the majority of slings are made from mesh. And back in 2011, the FDA reported serious complications associated with surgical mesh for transvaginal repair of pelvic organ prolapse are not rare. And unfortunately, slings got thrown in this same boat. Even though the amount of mesh that was being put in during pelvic organ prolapse was the size of 2 hands in some cases, and we're putting in mesh the size of my little finger. There were and are reports of mesh erosion extrusion. I mentioned that earlier. Pelvic pain, pain with intercourse, organ perforation, vaginal scarring, emotional problems. Fortunately, this is extremely rare with a sling. With the old mesh kits for the pelvic organ prolapse, if you had somebody who was not quite as experienced, who didn't account for the mesh to contract and different things like that, there were problems, and there were issues with the rollout of that, and there's we'd have a whole nother discussion about that. I would not suggest to any of my patients something that I would not and have not suggested to my own family members, and I personally feel that the risk of using mesh for a sling is far lower than the potential benefit as far as life-altering quality of life. And that's another thing that we go into with personal discussion during the interview process of the visits. So next, we're going to move on to the other common type of incontinence, and this is urge incontinence, which is often associated with urinary frequency, urgency, but we're focusing specifically on urge incontinence, although the treatments for frequency and urgency are very much in the same realm as with those things. So I have patients sometimes, in fact, I had patients today ask me on a telehealth visit, well, how frequent is frequent? How do you define frequent? And I think in the real world, that's patient defined. But in the urologic literature, it's defined as more than 8 voids in 24 hours. The definition of urgency, according to the urologic literature, is sudden, uncontrollable urge to urinate, sometimes associated with the loss of urine. And that's what's urge incontinence. Variety of risk factors for this type of thing, very common, more common than stress incontinence. But those risk factors include medications, so things like diuretics, things like stimulants, different things like that can make people urinate more frequently, more urgently. Constipation. We use a lot of the same muscles to eliminate our stool that we use to eliminate our urine. And so if those muscles are irritated because of chronic constipation, that can also lead to problems with frequency, urgency, urge incontinence. Radiation. So radiation is used for a variety of different cancers, cervical cancer, colon cancer, things like that. That can cause an impact to the bladder functioning. Low back issues. So the nerves travel through the spinal cord and they exit through the lumbar and sacral area. And so if somebody has nerve impingement, nerve irritation from a back injury, back surgery, that can lead to these symptoms. Urinary tract infections, diabetes. Diabetes, it's a tough disease, impacts everything from the eyes to the toes, including the bladder. And specifically, sugar in the bladder is an irritant, so we shouldn't have sugar in our urine. When the blood sugar gets really high, we spill sugar into our urine, and that's not only an irritant, but it's also a diuretic. So not only does it make the bladder more sensitive, it also makes us make more urine. So that's kind of a tough combination. Neurologic conditions like multiple sclerosis, stroke, Parkinson's, those all can have an effect on bladder function as well. Finally, something that I think is really common, but not often discussed, is something called dysfunctional voiding. Most of us, except for weird people like me, don't really think about urination on a day-to-day process. How do we urinate? How does that function occur? And so, but when you think about it, it really is quite a complex circumstance. Because when we're sitting here chatting and you don't want to urinate, we're asking your bladder to be relaxed. We're asking your sphincter muscle to be closed so you're not leaking. And we're asking your pelvic muscles, what we call the pelvic floor, this bowl of muscles that holds everything up, to be supportive but not restrictive. Then, after this talk is over. If you need to go to the restroom, we're going to ask all of those processes to reverse. Pelvic floor relaxes, sphincter muscle opens, bladder squeezes. Well, dysfunctional voiding is when those things are not working in a coordinated fashion. So bladder may squeeze, but pelvic floor may not relax, sphincter may not open up all the way. And so that dysfunction causes bladder irritation, which can cause frequency, urgency, urgent incontinence. And our solution for that is not surgery and not medication. It's pelvic floor physical therapy working to retrain those muscles. Our workup and evaluation for stress incontinence is pretty similar to urgent incontinence. Again, history and physical. History can be done virtually, telehealth from the safety of your home. Same sort of adjunctive testing, same sort of questions that we ask for the other for stress incontinence. The first couple of treatments are similar: lifestyle modification, pelvic floor physical therapy, but then we get into some different treatments, which I'll go over. When it comes to lifestyle modification, there's so many different factors that can influence the urination. We really spend some time going over these things. So things like spicy foods, acidic foods, alcohol and caffeine, constipation, management of diabetes, those are all things that we really try to talk about. Now, I'm not qualified to manage your diabetes, but I can at least work with you in a multidisciplinary approach and with your primary care doctor or endocrinologist to say, hey, we really need to attack this from multiple angles. Next, we have medication approaches, and there's a couple of different, there's two classes of medication, at least oral medication, that we use. The traditional medications fall into something called anticholinergics. These would be things like oxybutynin, ditropan, detrol, Vesicare, Toviaz. These are all different chemical compounds, but they have the same mechanism of action, and that is to block the cholinergic receptor on the bladder. And these have been shown in clinical trials to increase bladder capacity, reduce frequency of urination, reduce urgency, and reduce urge-associated leakage. Unfortunately, there's also cholinergic receptors in other areas of our body, including in our eyes, our salivary glands, in our intestine, and in our nervous system. Some of the potential, and I emphasize potential because certainly not every patient gets these side effects, but potential side effects would include dry eyes, dry mouth, constipation, and in some cases, confusion. I don't know anybody who's signing up for those things. It doesn't happen in everybody. It's kind of like the disclaimer at the end of the television commercial. And so we use a variety of these different products. And because these are quality of life issues, you as the patient are the driver of what choices you make. The other driver is your insurance, but that's a whole other discussion. The other medication is a newer agent called Myrbetriq. And what this does is it works on a different receptor called the beta-3 receptor. And it has some of the same mechanisms some of the same effects as far as reducing frequency, reducing urgency, increasing bladder capacity. It does not have a lot of the same side effects. Now, just like any medication, if you look in the package insert, you're going to see a whole list of things that can happen. I'll be honest with you, I have patients on this. I have patients on all of these medications. The side effect profile from Myrbetriq is in my experience, in most patients, it's better tolerated. And again, that's not every patient. Everything is individualized. On a large scale, I think Myrbetriq has a better side effect profile than many of our anticholinergics. Maybe not all, but many. The big negative of Myrbetriq is cost associated with it. There is no generic, and so that can be an issue sometimes with insurance. But again, it is what it is. I think as far as medications go, it's a good one if there is such a thing. But what do we have besides medication, besides physical therapy? We use our physical therapists for this as well. We also have Botox and nerve stimulation. And so Botox is used for a variety of things. It's used for everything from cosmetic reasons to eye muscle spasms to esophageal spasms. Well, Botox paralyzes muscle. And so the reason it works for cosmetic reasons is because wrinkles are scrunched up muscle. Well, I don't particularly care about wrinkles in the bladder, but what can happen in some cases of urgent incontinence is the bladder just has a major contraction that overwhelms the system and urine comes out. And so by injecting Botox into the bladder, that can reduce urgent incontinence. This is a straightforward in-office procedure. From the start to finish, takes about 90 seconds. What we do is we insert a scope into the urinary channel. There's a small needle that goes through that scope. We inject the medication in about 10 different spots. Takes a couple of days to kick in. Typically lasts for about 6 to 9 months. One benefit is you're not taking a pill every day. One negative is you got to have repeat treatments. Insurance coverage for this is variable, although I think it's getting easier. When this first came out many years ago, it's been around for more than 10 years, it was challenging at times to get insurance to cover this, but I think that's getting easier and easier. Sometimes we have to demonstrate failure or side effects from other medications. The one concern that is expressed with Botox is in rare cases, it can work too well and make it so that your bladder doesn't contract enough and so that you can retain urine. Now that's temporary. It's not a forever thing, but it's a little frustrating when you go from urinating all the time or leaking all the time to not being able to urinate. And that's treated with either self-catheterization or a catheter in the bladder. I've had that happen in a few instances. In all cases, the patients have recovered within a few weeks. So it's not like it's a forever type thing, but it is a risk, and we have to have discussions about those risks. The reported incidence of that is about 1 in 15 patients. Personally, I've seen it less frequently than that, but that's the published data. So I think Botox is a good alternative to medication. I've had some good success with it. I've also had a lot of good success with nerve stimulation, which is our other therapy on this line. Nerve stimulation can be done in 2 different fashions. One is called peripheral nerve or posterior tibial nerve stimulation. So this is an in-office procedure. I call it that. It's really not that much of a procedure, but it's done weekly for 12 weeks. So the biggest knock on this is the time commitment. So you come in, we put in this little tiny electrode, almost like an acupuncture needle. It goes into the ankle, right behind the near the ankle bone. There's a nerve there that shares some of the same circuitry as the bladder nerves. And so you sit there and read a magazine for 30 minutes while this stimulates. And it tends to build up over time, and we see a reduction in those symptoms. About 60 to 80% see improvement. I'd like to see that number higher, but and it's hard to predict who will or who won't. And oftentimes people have to have sort of touch-up treatments, if you will, about every 6 weeks. So you do the initial, typically what I do is 6 treatments, reassess, see if we're moving forward, see if things are going in the right direction. If they are, do the second set of 6 treatments, and then do 1 treatment at 6-week intervals. I've had some success with that. I think it's a good therapy. I think it's certainly really no risk to it. Biggest risk is you get bored in the office because you're there for 30 minutes once a week. The other type of nerve stimulation is something called interstim. And interstim has been around for decades. And it's pretty amazing. I don't really know the history of who thought this up, but they were pretty amazing thoughts, because this really it kind of revolutionizes the way we think about urination. And what this is a nerve stimulator that just goes under the skin. It does not touch any nerves or anything like that. And there's 2 parts to it. Again, I'm not sure if you can see my arrow here, but there's a generator here, and that's shown here with the relative size. And this is actually getting smaller and smaller. And then there's a little wire that just comes down here. And what happens is that generator emits a very, very mild electrical signal that influences the nerves to the bladder that in many patients significantly reduces frequency, urgency, and urge incontinence. This is done in a 2-phase process. The first phase is a test phase, which can be done in the office or in a surgery center. We numb up the skin to the back. We slide a little wire just under the skin, and then that wire is connected to an external little generator. It's like an old-fashioned pager. And we have people wear that for a couple of days to a week and keep a diary of their urination. And if we see significant improvement, then we go back for what's called a full implantation. That's a minor procedure. It's done under sedation. It does not require general anesthetic. We slide a wire under the skin, but this one's got some method of keeping it fixed in place. We make a small opening in the skin in the backside, kind of in the hip, and we drop this battery in. And then there's a controller that we're able to turn it on, turn it off, turn it up, turn it down, change some of the programming. Now, once we get this in and we have it set to the proper settings where you're happy with the urination, you put that controller away. You don't have to have that with you all the time. It's not like, oh, I got to urinate, let me pull that controller out. No, that's just allows us to turn it on, turn it off, assess the settings, that sort of thing. I'm pretty fascinated by the InterStim. I've had some patients whose lives have really been just, people who are just debilitated by their urination really get significant improvement with the InterStim. So, that to me is kind of exciting. I think that's amazing when I see somebody who's been on all these different medicines. They can't function. They can't spend time with their kids because they're always running to the bathroom, can't go to the movies, anything. And then, they get one of these things. We just see dramatic change in many patients. Unfortunately, not all, but in a lot of patients. That's kind of a summary of the urgency. And I tried to leave a little bit of time here for questions. I think that this is unfortunately something that a lot of women deal with. I think a lot of women aren't aware that there are treatments for incontinence. And I'm happy to say that we have a lot of treatments, and we have a lot of we've had a lot of great success. And we do that by partnering with our patients, by offering a multidisciplinary approach, and by really trying to meet your goals as individuals looking at these different options. And we really appreciate you taking the time to spend with us tonight. Excited to be part of Colorado Urology. Excited to have this new opportunity for patients to see us through the telehealth. So please visit us on our website. And I'm going to stop there and take any questions.
Thank you, Dr. Webster. We do have a question, and this one says, how long does the sling surgery take, and what is the recovery time?
Excellent. And I think, there's kind of two parts to that question. The sling surgery typically takes about an hour. There's multiple facets to that, both the anesthetic aspect, getting into position, doing the procedure. But you're looking at about an hour. It's outpatient, come in and go home the same day. Can be done in a surgery center, which can be more convenient, more cost effective. As far as recovery goes, there's different aspects to that. We really want that material to get some time to settle in and really kind of have some nice healing there. So we really want people to avoid significant exercise, straining, lifting, things like that for at least 2 weeks. And then the other thing is we really want to leave that 2-centimeter incision alone. So we don't want anything in the vagina for at least a month, vaginal intercourse, tampons, things like that.
Okay, we have another question. If someone already has a pelvic sling for a prolapse, are other slings a possibility?
And that's one of those things where we really have to get into the history of what's been done, because a prolapse is treated in a different way than a sling for incontinence. Prolapse is when the bladder itself drops and needs to be supported. We do not use mesh for that anymore, although I think mesh was a good application for it if done correctly. Now I use a biologic material, which is basically comes from human or animal, to support that. So if somebody's just had their bladder lifted and they have not had a urethral sling, yes, you can have a urethral sling. If you've had a urethral sling in the past that's failed, we really have to explore, why has that failed? Was it an issue where it just wasn't put in tight enough? Is there something else going on? That sort of thing. So that's I think a more complex question than I can answer without specifics of the prior history. But I think that that's definitely something that we can look at. And if somebody's had a bladder repair, yes, we can still do a sling.
We have another question here. What is your opinion of the Mona Lisa procedure?
So a Mona Lisa touch is a laser treatment of the vaginal area, and it's typically, there's a variety of different indications for it. We commonly recommend it for women who have vaginal atrophy postmenopausal. So after a woman goes through menopause, it's not uncommon for the vaginal tissue to change. There may be less lubrication. The cell types may vary, which can lead to dryness, discomfort with intercourse, recurrent urinary tract infections. And so the Mona Lisa touch is an alternative to estrogen, where a laser therapy, typically applied over 3 treatments, stimulates the vaginal mucosa to regrow in a more robust fashion, which can lead to more lubrication, less discomfort, and a healthier environment, making it harder for bacteria to grow. I'm not familiar with it specifically for incontinence, but we do offer Mona Lisa touch through Colorado Urology. More commonly with the indication of recurrent urinary tract infection, some cases of discomfort with intercourse, that sort of thing. But I think for those indications, it works quite well.
Okay, thank you, Dr. Webster. We have another question. Does the PT help with having to run to the bathroom as soon as you get home and the urge to go when you drink water or tea or other fluids?
I think physical therapy can help in a variety of different ways. How can it help in that particular thing? What you're describing is urgency associated with a trigger. We call it the keys in the door phenomenon. Somebody's coming home and they put their keys in the door and it triggers their bladder. They got to run. Sometimes people will hear that with running water, that sort of thing. So physical therapists can work with you on disassociating with those symptoms, but also with trying to identify contributing factors. So for instance, if somebody has muscle dysfunction that's causing that bladder irritation, then yes, I think physical therapy can help with that. Unfortunately, many of these problems are multifactorial, so there's not a one thing fixes all. Otherwise, there would only be like 2 slides in the presentation because we'd just be talking about one thing. But I do believe physical therapy can be beneficial either on its own or as an adjunct to other therapies.
Thank you, Dr. Webster. We have a couple more questions here. Can a sling be done at the same time as a hysterectomy?
So yes, that's a common thing. Now, as a urologist, I don't personally perform hysterectomies, but I oftentimes will work with my gynecologic colleagues. Say somebody has fibroids and they're going to have a hysterectomy and they've been dealing with stress incontinence, and they say, well, can we manage these things both at the same time? We do that commonly. So we work very closely with our gynecologic colleagues, and those both can be done at the same time.
Last question. How long does the interstim last?
So it's interesting because I think, the interstim started off, more than 20 years ago in one design, and like say an iPhone, it's undergone, redesign year after year to make it smaller, to make it last longer. Because it's like a pacemaker in a sense. It has a battery in it, and so that battery does have to be changed periodically, and the frequency of change depends on the settings. So, much like a light bulb, if you have the light on 24 hours a day, it's going to burn out quicker than if you only have it on 1 hour a day. But 5 to 10 years currently is the average. I can't speak to upcoming developments in that, but I've heard they're constantly moving towards making that better. And I don't know that this is going to happen, but I could envision a day where somehow that battery is rechargeable. Much like you can set your cell phone down and not actually plug it in, it can charge, kind of a similar type circumstance. So currently 5 to 10 years battery life, but I think that's something that's going to continue to evolve.
Great. Thank you, Dr. Webster. We just got another question in. My urologist suggested a device that I could buy on the internet. I ordered Attain. Can you comment?
I'm not personally familiar with that particular device. So I think the short answer is no. Now, most of the devices I'm familiar with are centered around trying to help people with exercises, pelvic floor strengthening, trying to give them feedback to say that, yes, you're doing it correctly. And I'll have to do a little research on the Attain. That's not one that I'm personally familiar with. That certainly doesn't mean that it's inappropriate. I admittedly don't know everything. My wife reminds me of that daily. But I'm not familiar with the Attain. So I'll have to follow up on that, and I'll be a little bit educated after this as well.
Thank you, Dr. Webster. At this time, we have no further questions. So participants, if you have anything that you would like addressed further, please feel free to visit our website, coloradourology.com. You can also schedule telehealth appointments with us, and we'd be happy to further answer any of your questions during that time. You can also reach us by contacting our office at 303-444-9000. Thank you so much for joining us tonight, and thank you for your time.
Thanks, everybody. Be safe and have a good night.